This is a particularly timely subject. While the rise of outpatient care and ambulatory surgery centers has been a trend for some time, the pandemic has certainly accelerated it. For the first 9 months of this year, for example, one of the largest hospital networks in America, 184 hospitals and more than 2,000 sites of care, that's HCA, reported a 5% decline in inpatient cases, but a 6% increase in outpatient cases. And if you compare the current inpatient activity to pre-pandemic levels, say 2019, it's down 11%, while outpatient care, in fact, set a new record this year. No question, this is a timely subject, and outpatient spine care will play an increasingly important role for most spine and neurosurgeons. And to discuss moving your lumbar fusion outpatient, we have a really outstanding faculty tonight. Joining us this evening is Dr. Michael Wang, Chief of Neurosurgery at the University of Miami Hospitals, where he also serves as Spine Neurosurgery Fellowship Director and is a professor with tenure of the Departments of Neurosurgery and Rehab Medicine. Also with us this evening is Dr. Stéphane Lavoie, a fellowship-trained spine surgeon practicing at the Florida Orthopedic Associates, and Dr. Larry Koo, who is director of the Spine Clinic in Los Angeles and affiliated with the UCLA Medical Center. And a quick note to our audience, please make frequent use of the Q&A button at the bottom of your screen. And just as a starting point, can you talk about how that trend of moving spine surgery to the outpatient setting, how's that been part of your practice, and how have you adapted your practice in order to do that?
I think, like all of us who've been doing minimally invasive spine surgery for some time, the natural evolution beyond just minimally invasive techniques is a minimally invasive surgical procedure, meaning everything from the time the patient is diagnosed to the time he's admitted to whatever facility we're talking about for a surgical procedure to the time he's discharged in the follow-up period after. So minimally invasive implies philosophically that we've been looking at every step from both the instrumentation to the surgical techniques, to the pre-anesthesia, to the pre-screening, to the post-operative management. All these ergonomic efficiencies and proper selection and modifications of procedures and techniques really have been focused on one goal: to make the impact of every single spine surgical procedure less and less, to the point where it's optimized, that it's almost predictable and it's least impactful. Because the difficulties when we started spine surgery, these were big procedures. Even a 2-level fusion was a 1-week stay in the hospital not so long ago, 20 years ago, 1995, 2000. The difficulties from a cost perspective, from the patient's health perspective, especially with our aging population, we could not continue in that vein. So everything we've done, from technology to procedural solves to mastering the ergonomic workflow and anesthetic protocols, these are the kind of key touchstones that we've evolved and looked at over the last 15, 20 years to make outpatient spinal fusion 1 and 2 level now not just a goal or a possibility, but a very much a reality of day-to-day fact.
I think the pandemic had the effect of maybe accelerating this trend. And in a sense, it produced new kinds of stresses and strains on the hospital system. Doctors, what do you do to bring surgery to high-risk patients and in the process minimize hospital stays? And Dr. Wang, if you don't mind, I'll start with you.
Oh, thank you, Robin. First, let me start by saying that I'm a big fan of yours. I've been following you for a decade now. You've done an amazing service for our specialty in spine surgery. So thank you for that.
Thank you.
During the pandemic, we transitioned significantly, and I'm not running a surgery center per se. I'm an academician, as you know, and we have never been busier. And I don't just mean afterwards. I'm probably at 200% of pre-pandemic volume in clinic and surgery. And a big part of this has been our transition to prepare for treating the most difficult patients in the most difficult environments. And I apologize for the long answer, but it's a very complex question you're asking, which is that if you think about it, during the pandemic, only the most desperate patients came out for surgery. And so I want to tell you that about 5% of my operative patients during pandemic, I'm talking about before everybody reopened, were transplant patients that couldn't live with their problems. And so it was a very, very interesting time. And I'm happy to share whatever detail you want as we go into this, but I want to, just sort of open with that, if you will.
That's terrific. That's very interesting.
Well, I agree with Mike. The population in Florida has definitely aged. We certainly have an influx of younger folks as well. But for me, it's been a big part of my practice for a long time to operate on the elderly. And it's always a balance and trying to help and prevent complications. I found that an aggressive approach, the operations that I did in my fellowship would not work for a lot of my patients. And so moving forward and developing those lesser invasive techniques, it was over time became more and more natural that I realized that patients were doing quite well, and that the post-operative period was much easier for them. So I've actually been decreasing my length of stay for quite some time. And around me, compared to other surgeons, my length of stay has been rather low. And I attribute that to the minimally invasive technique. Now, the pandemic has forced us to push it to the next level, but not being in the academics, I can't say that we have everything lined up like Dr. Wang, but my technique in itself was definitely amenable to a more aggressive outpatient work.
I'm thinking about, 2020, and it wasn't that long ago, spring of 2020. We probably can all remember cases in the operating room as surgeons where when a patient would come in for maybe elective or maybe emergency surgery, and maybe they wouldn't be even tested, or maybe they were COVID negative, and people were running out of the room during the intubation. And they had this thing like you had to be out of the room. Do you remember this, Stefan? It was weird.
5 minutes outside of the room after intubation.
Yeah, and they would leave like the student CRNA to do the intubation because they were the youngest person, and the older anesthesiologist didn't even come to work. It was a very bizarre, surrealistic time. And during that time, we were doing these cases without general anesthesia, which, it changed the calculus because people were saying, okay, well, they're patients in the hospital with a mask on, so we'll just put some nasal cannula oxygen and a mask on, and we're going to do the surgery. And it definitely, during that time, I think, struck us as a real game changer in terms of what we were doing. But it really required those pieces, and we had to have some proficiency beforehand. And so during pandemic, I got no shortage of people calling, like, how are you doing outpatient awake surgery with OptiMesh? And the answer was, well, I wouldn't start it now. I would start it ahead of time. And that's why coming out, and who knows about Omicron, but it doesn't sound like it's as bad. But as we come out of this, people, I think, have now realized that, okay, well, the next threat may not be coronavirus. It might be, the next form of single payer, or, whatever that next crisis is. It's not going to be like the coronavirus. It's going to be some other gigantic existential threat, or reductions in payments, or limitations in hospital stay, or cash only business because they don't approve surgery for spinal fusion. Like, these are the things that are coming. So I would encourage listeners out there to prepare today. Orthopedic neurosurgeons, prepare today for the next major crisis, if you will, in your practice.
I have to comment on something else you said, Dr. Wang. You were talking about during the pandemic, your patient risk levels seemed to be generally higher on average. In those kinds of high risk patients, looking back on it, what did you do to kind of minimize, if at all, their length of stay? Again, given their high risk status.
The nursing crisis was the problem. It was not the coronavirus per se. It was that for various reasons, there weren't enough nurses. So they're like, you've got to reduce the length of stay, because they wouldn't, for example, there was a time at Miami, and I know people think you watch the news, it's mostly false. They're like, oh, Miami's just crazy, or doing whatever. Those were New Yorkers partying on South Beach. We were just taking care of patients through all of this. And, they would say, well, okay, we will only allow like 7 admissions today electively for the hospital, and there's there's 22 ORs. Who's going to get to admit? And if you admitted people and they stayed too long, they're like, well, you're just creating too big a burden. And it was nothing to do with coronavirus per se. It was there weren't enough nurses. I don't care which side you're on. But the funny thing about it was, you're right, Robin, this same thing is going to happen again. So I think that what Stefan was saying about using the adjuvant treatments, the protocols, the ERAS protocols, the minimally invasive endoscopic, you need it all. You can't just use one and expect that your length of stay is going to be cut in half. You've got to have all the tools. And for me, doing it endoscopically through a 7 mm portal, using OptiMesh, being able to get a fusion was huge. Because it meant that we could do and I know Stefan does a lot of outpatient surgery. I generally don't do outpatient surgery. I try to keep the patients overnight. But during pandemic, the height of it, we were discharging patients same day because we had to.
I think the pandemic created an impetus or a series of market forces, if you will, that pushed the patient and the surgeon into the outpatient setting. To your point, Robin, perhaps prematurely so in some cases, but nevertheless, the fact that, number one, most major hospitals shut down their operating rooms for a period of time in different parts of the country, but all the states at some point in major cities, major hospitals, HCA type facilities would shut down their facilities, no elective surgery. Some institutions, my gosh, have been shut down for a year without doing elective spinal type procedures. So that, of course, created an immediate force to push surgeons to look for venues where they could treat patients electively. Of course, many hospitals during that time had an exemption for emergent type procedures or impending neurological deficits, but that still left a very large egg, if you will, of procedures that are really truly elective in many ways that needed a place to be done. So this led surgeons who, needless to say, a select group of surgeons who are already potentially comfortable with minimally invasive type procedures, to say, you know what, perhaps I can do I already do one level discectomies and one level cervicals in an outpatient setting. Why can't we progress and say we do a one level and a two level fusion in an outpatient setting? So that is the clinical force, again, linked to many ways the pandemic shutdown, that forced surgeons to this. Then third, there was the market force of the patients themselves. Patients like, I don't want to go to the hospital. That hospital has 260 COVID patients in it. They're using waiting rooms and cafeterias as COVID overflow units. So clearly, nobody in the right mind wanted to come to a hospital for an elective procedure, given the chance that you getting COVID, not to mention the horrible environment that you would have to recover in, would make it such that even your family couldn't visit you, couldn't bring you to the surgical procedure. So all those kind of ground level factors made it such that patients themselves were like, oh, wait a minute, I don't want to do this. Even if you can do it, I don't want to do it in an inpatient setting. And so that was the third market force from the patient side that drove a lot of us to start to do these 1 and 2 level procedures. However, to your point, Robin, sometimes in situations like this, what they say, necessity is the mother of invention. Unfortunately, sometimes the necessity pushes us too fast. And between surgical centers not having the anesthetic protocols, surgical centers not having the ability to recover or do overnight stays in some states where ASCs are mandatorily same-day discharge, and also when certain ASCs and surgeons did not have all the potential issues to like ability to transfer, like say if the patient needed to stay, or for that matter, surgical equipment, navigation, all these things made people realize that in elderly, higher risk patients with more technically demanding type surgical procedures, pushing them to an outpatient setting just because you can do a 1 level lateral or you can do a 1 level TLIF in an inpatient setting perhaps was premature. And certainly, for example, anterior type approaches, which require vascular surgeons in some cases, or when things go fine, don't need a vascular surgeon. But if you do anterior lumbar surgery routinely or OLIF, oblique lateral type surgery routinely, you're going to have a vascular complication at some point in time, and not having a vascular surgeon or an ability to transfer to an inpatient ICU or ER type setting, created certain problems. So again, to your point, pandemic created this perfect, whatever you want to call it, pressure cooker of all these market forces pushing us perhaps a little too quickly into the outpatient setting, but also by the same token, successfully letting us know that we can do it.
I'll say that I've actually changed my post-operative course a few years back, trying to reduce the amount of narcotics being used. From an anesthesia standpoint, I was always intrigued with Dr. Wang's technique, but it was not something I was able to really implement. I found that emphasizing more recently, at least, in post-op local anesthesia has made a huge difference. So I've been a pretty big user of Expro, certainly since the pandemic. And I will tell you that I've done a lot of outpatient fusions, and my readmission rate has not increased. I think actually it's lower.
Would you take a couple minutes perhaps and walk through sort of your technique, maybe with Optolift or the other ways? So kind of show the audience in some rather specific ways how it is that you are able to do something in that kind of time.
Sure. I believe that a transforaminal fusion without bone resection can be an answer to this. And so the question is, how do we access it? What kind of discectomy do we get? I have seen a lot of patients, as Dr. Wang was mentioning, pseudoarthrosis with T-lifts. And I believe a lot of times it could be because the disc prep wasn't appropriate. How do we address the stenosis, the leg pain? How much reduction do we get? What size implant can we use? And so looking at the access on a canvas triangle is rather large. The technique I use with a 7mm portal fits nicely into that opening. The access I usually do with direct, with X-ray visualization. This would be, for me, a very perfect access, really, in line with mid-pedicle at the posterior aspect of the vertebral body. The technique calls for a drill to open up the disc, an implant that we call a disc shaper that allows for some preparation initially in a channel in line with the implant, followed by certain curettes that will allow a more circumferential discectomy. The technique also calls for some brushes to be used. Some surgeons would remember the Trans 1 technique with those brushes. So this is a reminiscent of that. And then this is the discectomy I was talking about. I like to get a balloon discogram, and that way I can see the completeness or not of my disc preparation. I've been doing this for a long time. I do a lot of them, and every week after a discogram, I'll go back and I'll work on the disc space a little bit more. Maybe it's a little OCD, but I believe in the prep. A discectomy like this, to me, is not acceptable. I would be concerned with that. I would go back in and I would prep that disc and that end plate further. Then we talk about reduction. So what do we do? Do we always do a laminectomy? Do I always open and go in the canal? And the answer is certainly no. I find that indirect decompression works extremely well on a spondy that can be reduced, a collapsed disc with more foraminal stenosis. The question becomes, what do we do with a severe stenosis? How much opening of the canal do we need? If we open the canal and reduce the slip by 2-3 millimeters, does that set the patient back where they were 5 years ago, 3 years ago? I don't have the answer to that. I still feel that most patients that have a lesion in the canal, whether it's a synovial cyst or a large herniation, would benefit from direct decompression. I don't think we can rely solely on an indirect decompression in those cases. A couple of examples here, maybe of a patient with a slip and looking at the axial view. Certainly more lateral recess stenosis than central stenosis. And so to me, a patient like that, I would have no hesitation in recommending an indirect approach. Patient like this, I don't know what Dr. Wang would do. The slip is there. You can tell the synovial fluid, and so there's definitely some instability. I feel that a patient like that, I would get a good reduction of that spondy, and I would probably consider maybe an indirect now, although in this particular case, I ended up doing a tube decompression. And the reason why I've been a little bit more aggressive, I believe, in my indirect decompression is I've been relying a lot on the distractive forces that I obtain from the implant itself. The impaction allows me to feel the forces across the disc space, and I can actually see it on the X-ray. And this is an example of a case I did where this is 100% the implant doing the reduction. So there was no real reduction on positioning, and upon distraction of the disc space, we get a very adequate restoration of disc height, and maybe not a complete restoration or reduction of the slip, but significant enough. I wanted to bring forward some results. These are this is an extract of the SCOUT study that led to the FDA approval of the implant. And we extracted 43 patients from the study that had an indirect decompression. And we found that their resolution of leg pain and back pain, but in this case, I want to point specifically at the leg pain, that the leg pain resolution is tremendous and persists all the way through to 24 months. And I think that's very telling, looking at this particular technique. Again, if we look at ODI, patient satisfaction, again, those are regarding the indirect patient. And in that study, we had measures of leg pain pre-op, post-op, back pain pre-op, post-op. So this has been pretty well established.
Dr. Wang, any thoughts on the and thank you again, Dr. Lavoie. That was exactly what I was hoping we could do for the audience. Dr. Wang?
I mean, your question originally, and first of all, Stefan's showing some excellent data there about what you do if you're trying to adopt these techniques. You know, there's a lot of ways to approach it. I'll take it from a different approach. Stefan's showing the data, which I think should be compelling and convincing. I would say, okay, let's break it down into 3 different age categories. And I know that, again, I want to say that our emphasis is on the surgeon today because of the nature of this webinar. The emphasis truly is always on the patient and their outcomes. But because of this being a masterclass, I would say, okay, if you look at from the viewpoint of the surgeon, if you were an older surgeon, you might say, okay, well, I will probably retire before this wave hits, and I think I'll just keep doing things the way I always have. Or you could be very forward thinking, like my good friend Charlie Branch at Wake Forest, who says he loves doing endoscopic surgery because he's like, well, it's actually ergonomically easier for me as an older surgeon, and I don't have to slog through all the opening and closing, all these things. There are some real efficiencies built into the percutaneous procedures that Dr. Stefan does that actually make surgery in some ways very pleasant and almost stereotyped in some ways. I don't want to make it sound simplistic. It's not, but there's a certain routine to it that makes it more reliable and predictable. If you're in the middle age group, so you're like in the sort of the master surgeon class, meaning that you're at the peak of your technical abilities, it's really hard because, you know, how do you convince those people to change what they're going to do? And the answer is that, well, the things you're doing now today probably are going to become obsolete before you retire in many ways, particularly with lumbar fusion. And so I would say, well, the compelling answer is if you want to practice medicine past the age of 55, 60, you might want to think about trying the newer techniques to better understand where the field is headed so you don't become obsolete or you don't suffer from technical senescence. For the younger surgeon, there's no question. There's no chance for you unless you begin to think about surgery differently. If I had come into surgery as I did in the mid-90s and I said, well, I'm going to do this. The new thing was they had a new thing called lateral mass screws, but we learned a lot of wiring. If I said, well, I don't need that, I'm just going to wire people's necks for the rest of my life, Well, I can't even tell you where I'd be now. I'd probably have to practice in North Dakota or something like that. So be ready, but remember also the things that Larry and Stefan and I are telling you, they're just the beginning. There's newer, cooler stuff coming for treating bigger problems less invasively. And so I would just sort of leave you with that idea that depending on where you are in your journey, you might have a different opinion on how you interpret what we're telling you.
Yeah, that was terrific, Dr. White. It's really good stuff. Actually, I do want to turn our attention to the aforementioned Dr. Koo, who has done a number of lateral procedures. And as you know, lateral procedures can take more time, multiple patient positions and so forth. So I'm going to pose the question to Dr. Koo, and that is, what, if you're working in the lateral, if you decide to use a lateral approach, what is your key for minimizing the patient's length of stay?
I think given what Mike's saying in terms of, yes, the market forces are there, patients are asking for it, demanding it. But the question is, at the end of the day, every surgeon must on their own make the decision of whether or not you want to constantly evolve, or do you want to master the things which you've gotten good at? And I think that's a very important thing. And also Mike puts it very well in the sense that it depends on the person, the surgeon, the stage of life they're in. And that's not necessarily a function of age. We know many people who, by the time they're done as residents, that is the last change in their surgical technique after their residency and fellowship training that they're ever going to make in life. And that's more akin to sports philosophy. If you've ever talked to coaches or people who train people for any type of sport or physical activity, there are what are called first adopters, people who are constantly evolving and changing. And then there are people who literally are taught to make the barbecue ribs this way, and that's the way they're going to make it because that's the way Chef Nobu taught them to do it till the day they die. And so I think that's really what we're touching on, because people can respond to market forces and evolve and become competitive, not to mention benefit their patients with constantly evolving techniques, or they can choose to stay the same. And I think the difference now in 2021 post-pandemic, and even just in this time of year, when we first started, minimally invasive had a very small, limited group of tools. There was barriers to education, learning these new techniques like endoscopic surgery, like Mike was talking about, to gaining access to the things in your operating, like an O-arm, neuronavigation, neuromonitoring. These were not readily available in all ORs, main ORs, not to mention even ASC settings, right? So I think that technological, training barriers, age, and personality issues, these four are the factors that really influence whether or not a given surgeon, I should say, will evolve into these minimally invasive techniques.
Let me drill down a little bit about procedures and techniques, a little bit more detail. Well, let's look at the lateral approach.
Yes.
Now, the lateral approach, one that you know well, how can you adapt that to doing spine fusion surgery in the outpatient? Particularly if you're changing moving the patient around on the table, how can you adapt that to an outpatient setting?
Absolutely. Well, like I always like to quote the famous Marine motto from Chosin Ridge in the Korean War. We don't retreat. We're not retreating. We're attacking in a different direction. And that's the key with minimally invasive lateral spine surgery, because at the end of the day, it's not front, back, posterior. We're just trying to get to the middle. We're trying to get to the middle because that's where the spine happens to be. It's in the middle. So that having been said, for lateral, for example, the lateral L-lift and O-lift techniques are incredible in the sense that let us march up the spine, put massive cages in, do incredibly great corrections, reductions, so on and so forth, best fusion outcomes, so on and so forth. But the lateral evolution, the O-lift evolution has made it such that procedure can be done with minimal neural retraction, minimal vascular risk, and it can be done quickly and elegantly. So for those people who've climbed the lateral curve, if you will, what used to be a 2-3 hour thing to do a single level lateral is now often a 30 to 40 minute event. For myself, having climbed that curve since 2006 when we did our first lateral procedures, a routinely one level lateral, about 45 minutes for the actual anterior procedure, and about 60 minutes to 70 minutes for a 2-level. So that combined with same position, posterior fixation, be it pedicle screws with or without navigation. Some people like robots, some people don't need robots. But regardless, you can put in one or two pairs of pedicle screws to back up that construct in also about 45 minutes.
Thank you, Dr. Koo. Dr. Lavoie, Dr. Wang, do you have any comments about that?
Yeah, so Larry's obviously an expert in lateral surgery. I like lateral surgery a lot. I don't do as much as him. I think that there's a real place for that. I mean, the things you can do with lateral surgery, especially if you can do it a little bit less invasively. And I know that he uses the Duo device that allows you to do a lateral approach through a much smaller incision than I think anything else in spine today. I think there's a lot of street cred for lateral now. There's a lot of reasons to do that, to restore lordosis, to get better end plate contact, higher fusion rates. I've never seen a lateral patient not fuse. I've seen posterior patients, posterior T-lift patients not fuse, but I've never seen a lateral patient not fuse. There are a lot of good reasons to do that surgery. I think if you're an artist in that, keep hitting at it.
So in an MIS approach, you're going to go your smallest incision, maybe fewest number of incisions, single position, least invasive possible. You're going to go for the least disruption to tissue and the neural structures. In that environment, using, for example, an expandable mesh implant with titanium blocks to get kind of a larger footprint, do some of those techniques really, how do they work in terms of managing procedure time and improving your methods to, again, be more efficient with your patients, even the high-risk patients? Dr. Lavoie, what do you think?
Well, in my hands, I typically use the mesh. Using an approach through Camden's triangle allows me to avoid bone resection. So that in itself means less trauma, less operative time as well. I can approach the triangle on the C-arm guidance. I do like monitoring, so I believe that neuromonitoring is a safe way to approach the disc from an extreme lateral approach. And certainly the disc prep was my biggest concern when I started doing these cases. And I'll tell you that after looking at my discograms post-prep, I'm very confident that I get a very good discectomy. I get a large amount of graft, and I think the footprint of that implant allows me to get a good fusion. And I think ligamentotaxis allows me to restore a lot of the alignment. I think that's important. Dr. Wang mentioned it, certainly from the lateral, you can expect the lordosis to be restored. But I've seen that also doing an implant with the mesh. And I have a lot of patients that have a great reduction of the spondy, maybe an asymmetrical disc collapse. I go on the opposite side and I restore the foraminal height that way. I think the preservation of the anatomy here and the force of the implant has been its greatest success.
That's a great answer. Thank you very much. Dr. Wang, anything to add?
I think it's interesting because, this whole conversation of lateral has changed over time.
Mhm.
Initially, there was one way to do the lateral, which was the XLIF procedure. Now we see a proliferation of methods, whether they be the ATP, the ACR, the OLIF, and now we're seeing the prone lateral and single position lateral. So here's my charge to all those people. And I've got a lateral deformity case tomorrow, for example. So I'm not against lateral. And as Stefan said, we published early on that data about thigh pain because we recognized it. But that's part of new procedures. It's recognizing the pitfalls and not avoiding them. I think that if you can reduce the lateral procedure to a small enough procedure, meaning small enough in terms of incision, you're going to change the conversation about this thing, about trans-psoas, pre-psoas, all that. Does it matter if you can get through the psoas small enough? I mean, how about the prone lateral thing? The prone lateral thing is very complicated because what if you said, well, I want to do prone lateral, but I seem to be getting a smaller quarter because the way the spine falls more ventrally and my axis is delimited by the approach, meaning that the pads are a little more in the way. I don't have full access at the front of the belly, all these things that limit you. But what if your axis was half the size of a typical lateral. Well, that would, of course, alter that conversation parameter. People aren't talking about that yet. But I think that what Larry's doing, I think it's going to change that conversation.
Specific to the surgical techniques that we use in the lateral position or for lateral, anterior lateral type approaches, the key is three things. One is an optimized access system that minimizes neural and vascular retraction needs. Now, that's a lot of talking, but it simply means whatever technique you're going to use for a lateral or an O-lift type approach to L4-5, L3-4, and so on. The key is you have an instrument set that A, will get you there, dock on the disc space, let you do a full discectomy and release in an elegant, safe, reproducible way with a minimum of neural retraction for visualization necessary, with a minimum of need to move blood vessels and things out of the way, and a minimum pressure on the surrounding existing tissue. So for example, we routinely use the Spineology's duo TI kind of access system. It's a simple tubular technique that accesses the docks on the disc space. And once we're there, we then ergonomically go through our steps 1, 2, 3, 4, 5, cut out the disc, prepare the end plates, and deliver an implant reproducibly quickly in a given 30 to 40 minute period per level. That's the key. Speed is good, but one step at a time, go slow to go fast, and then get it done within 30 to 40 minutes. And don't skip. And that's the key. We're not skipping steps. That's not what we're saying at all. What we're saying for myself to ensure good minimally invasive outcomes in short stays, the time of anesthesia, the time of neural retraction, the amount of dissection necessary, all by reducing that reduces the potential complication risk of neurovascular and muscular injuries.
A question for each of our faculty this evening. I'll start with Larry. Larry, how are you applying some of these MIS capabilities in your practice today? And in the case of California, what can you say about the future for outpatient surgery there?
What minimally invasive surgery did over the last decade and a half of its evolution and introduction, plus now the focus into the ASCs, it's made possible operating, of course, on young people in the outpatient setting. But really what's interesting is we've moved that little dotted line, the little goalpost, if you will, rather than goalpost, the boundary condition, if you will. But we used to say, if you're older than 70, maybe you shouldn't have this procedure, or maybe we can wait a while. And also by the time we wait, like the pandemic showed us, patients would come in with multi-level disease and we would have to do these larger operations. Now, I think with the pandemic outpatient ASC setting, we're beginning to realize that we can treat everything on a short event-based treatment paradigm, meaning that, we can just do 1 and 2 level stenosis decompressions infusions on a 75 or 67 or 75 or 78-year-old person and say that's not that bad. And people are like, so it's been a bit of a paradigm shift, because now that we start thinking about a 2-level lumbar decompression infusion, for example, or just a 2-level lumbar decompression as a outpatient event, all of a sudden we begin to think more like general orthopedic surgeons, where we don't do these large, massive definitive procedures at once over 8-10 hours of general anesthesia. We make them 1.5 2-hour events. And then we say, okay, we'll treat these 2 levels, see how it goes in the future. You may not need any additional surgery. So maybe we don't have to do T10 to the pelvis. Maybe we don't have to do the 4-level front back fusions. Maybe we'll just treat the 2-level stenosis, stabilize those levels, and see what happens.
There's an old axiom in orthopedics that during times of war, that's when you get the greatest advancement in innovation and knowledge. Perhaps the pandemic was this generation's, in a sense, external event that drove a lot of new thinking out of, as you say, mother of invention, out of necessity. What, in terms of where you are in Florida, and as you're applying some of these capabilities to your practice, what can you say about the future of outpatient surgery where you are?
I will tell you that the hospital systems around me all want to be part of surgery centers, because I feel that they see the data probably more than I do, And there has been a tremendous push for outpatient surgery in all fields. My partners are doing their joints outpatient, general surgery, half of their elective stuff or more is all outpatient. And then in spine, it's going there. The challenge for us has been certainly to get the same equipment. Obviously, the hospital has a lot of C-arms, a lot of personnel, all the instruments that we want. So I think that's been a little bit of a challenge.
Great, great. Dr. Wang?
In the current era, I think we're on the cusp of a change. Up until probably a couple years ahead of from now, the outpatient surgery proposition has been an economic one. And anybody who's paying attention in spine surgery knows this, which is that surgeons who own surgery centers, they're incentivized to do outpatient surgery. There's a financial incentive in a way to do it. Even if you don't think it's an incentive right now. The danger is going to come when that becomes the mandate. So right now, people are saying, okay, well, I want to do outpatient surgery because there's a benefit to me, right? I can do these surgeries, I can generate passive income, et cetera. And by the way, in this conversation, I don't want to lose the importance of the patient. Obviously, patient safety and outcomes are the most important thing. So we're entering a higher level discussion. We don't need those disclaimers, right? We all believe in that. But the danger is going to be when we move to the mandated outpatient surgery, meaning that, oh, okay, so you can't do this outpatient. I mean, it's already gone that way, right? Every surgery we do, it says 23-hour authorization, even like a T10 to pelvis now. So when that becomes mandated, then where does that leave people if those mandates actually have teeth? Well, it leaves people on either a winning or losing side. I don't want to call it winning, but basically a losing side and a status quo side. And so I actually, I'm going to go out on a limb here and make a prediction that that day is going to come. So get on board with Dr. Lavoie's technique through Camden's triangle or Larry Ku's technique with lateral using duo. But if you don't have some answer to this, you're going to find yourself on the wrong side of that 2x2 table where the one side is cost and the other one's outcome.
So for surgeons who are not doing outpatient lumbar fusion surgery today, what advice would you have for them? And this is for each of our faculty members this evening. What would you say to them in terms of advice? How can they get started? What's a good way to get into this? Because I think you're absolutely right. Both of you are.
If there's any state that is more driven by a variety of factors, including economics, medical legal issues, and patient demand for less invasive surgery, I think it's California. California, perhaps Florida as well. But that having been said, the key things that are driving us in California to these procedures are, number one, like I said, patients are demanding because they see it across the board in all other fields, from hip replacements to knee replacements to cardiac procedures to general surgical procedures, to not to mention all the cosmetic procedures that we do here in California, but they're all done on an outpatient basis. Also, Medicare payments in California are the lowest almost in the 48 contiguous states, meaning that we get paid less per RVU here than almost any other state. The same ACDF pays 15 to 20% more based on the same number of RVUs Medicare in Chicago versus Medicare in California or Southern California, which is worse than Northern California. So the market forces for DRG payments, RVU payments, mandate that these procedures become minimized, more streamlined, more ergonomic and cost efficient. So that's the other second factor that's very unique to California. The third is we have more competition here than most states do. For example, if you put a pin in me right now and just draw a little 5-mile circle or 4-mile circle around me, you're going to hit about 100 spine surgeons. And so that in a very small area, we're all marketing and magically we're all minimally invasive surgeons. So that having been said, the other factor that California is probably leading the way in some ways is outcomes. We are heavily tracked because, as you know, managed care began here in California. Kaiser Permanente, the paradigm of managed care. And the one kudos to Kaiser is they track data more than even Medicare tracks data. And so Kaiser has their own internal data and they're very good at knowing who does what whose outcome is, and so on and so forth. And that's now true, not just for Kaiser, but across the board in Southern California. We all know our outcomes, we all know our costs, we all know each other's complications. So because of that, that third factor of kind of this weird California data-driven metric, if you will, again, forces us to become better at what we do and to generate equivalent quality of life year outcomes for a lower quality of life cost. And that's a really important factor, because simply put, the expensive surgeons with higher complications very soon will no longer get contracts for managed care from the vast majority of our managed care bodies and companies out here. So they very much are contracting with the data-driven outcomes. If they say, oh, you can do a, Dr. Koo, you can do a 2-level fusion for X amount of dollars for X amount of stay with this outcome, versus this other group who costs about 30% more than you, has on average higher length of stay, about the same complication rate, but you're cheaper. So, and your patients are happier. So we're going to go with you. And that's just a small example, but that unfortunately is a story that plays out daily in Southern California and Northern California because of our almost 100% penetration of managed care and managed care outcome measurements.
That's what I would tell surgeons that are not doing it yet, is they need to start understanding what we're doing, how we're doing it, the advantages. It's not unusual for a patient to come to me and for a second opinion, and they were sold on a 5-hour open surgery, 3 days in the hospital. And when I tell them that we can do this outpatient in under an hour, some don't believe it. They just don't understand how this other surgeon says it's a very complex surgery for hours, and I can do this in a less amount of time. So I think patients will educate themselves over time, and they will be able to see that there's an advantage. And I think the surgeons are going to have to follow. And unfortunately, as Dr. Wang said, if you can't do it, there's a lot of patients you will not be able to help.